Hello, my name is Dr. Leah Gramlich. I am a gastroenterologist, physician nutrition specialist, and I am a professor of medicine at the University of Alberta. It's my pleasure today to talk to you about case studies in ERAS cardiac surgery. My disclosures are listed. Over the next 10 minutes, I would like to use a case-based approach to describe nutrition care of two patients enrolled in ERAS cardiac surgery protocols. As I am doing this, I would like to outline nutrition care options and optimization of patients undergoing ERAS cardiac surgery. Let's begin with a discussion of the components of ERAS cardiac surgery. These were recently published by Dr. Engelman and colleagues in JAMA Surgery in May of 2019. As with all enhanced recovery after surgery programs, the programs focus on preoperative, intraoperative, and postoperative care elements or components that are associated with improved patients' outcomes. If we look at specifically the evidence-based care guidelines that focus on nutrition care, they include preoperative nutrition risk screening and correction of nutrition deficiency. It is supportive of prehabilitation strategies for patients who have frailty or significant deconditioning. It is a proponent of adoption of modern fasting guidelines, which results in reduction of fasting times for patients undergoing ERAS cardiac surgery. It can include the inclusion of a preoperative carbohydrate load using a complex carbohydrate solution. In addition, the ERAS cardiac surgery protocol advocates for the use of multimodal opioid-sparing strategies. In addition, it encourages the use of insulin infusions to treat hyperglycemia. Enhanced recovery after surgery protocols were first developed in colorectal surgery. If we take a step back and look at how nutrition care is optimized in ERAS colorectal surgery and the evidence that supports this, it allows us to consider the adoption of nutrition care practices in an enhanced recovery after surgery protocol in cardiac surgery. In colorectal surgery, nausea and vomiting prophylaxis through assessment and intervention has been an important adjunct to nutrition care. This is also supported by ileus prevention through laxative therapy and the use of non-opioid analgesia. In ERAS colorectal surgery, early mobilization, as well as the avoidance of tubes and drains, have been shown to be helpful in optimizing nutrition care, as has the appropriate use of IV hydration, specifically avoidance of fluid overload. In patients undergoing colorectal surgery, adoption of ERAS nutrition care elements have been shown to be associated with a reduction in time to tolerating first meals from 5.4 days down to 2.9 days. Another evolving paradigm in ERAS cardiac surgery is the use of prehabilitation strategies that include individually tailored exercise interventions to improve baseline functional capacity, dietary modification focusing on adequate protein nutrition and treatment of protein energy malnutrition, and the use of education and other strategies to alleviate pre-op anxiety and stress. This has been hypothesized to address issues related to sarcopenia, frailty, and delirium in this at-risk patient population. So let's jump into two patients undergoing ERAS cardiac surgery. Mrs. J.S. is a 61-year-old female who was admitted with swelling of the legs and shortness of breath. This 61-year-old woman is presenting with severe biventricular cardiac dysfunction, and she was admitted in cardiogenic shock to the ICU following the development of a pneumonia. At the time of this presentation, she is on pressors and continuous renal replacement therapy. Her past medical history includes non-ischemic cardiomyopathy secondary to viral myocarditis, and transesophageal echocardiogram has demonstrated that she has a left ventricular ejection fraction of less than 10% with severe diastolic dysfunction. The surgical plan is for insertion of a left ventricular assist device. As we look at her nutrition care, she has a positive nutrition screen based on the Canadian Nutrition Screening Test, which asks, has she lost weight without trying, and has she had reduced oral intake? She answers yes to both these questions. On physical examination, her current body weight is 68.1 kilos and her height is 162 centimeters. She has an estimated dry weight of 58 kilos and a usual body weight of 78 kilos, suggesting a weight loss of 20 kilos. On physical examination, she has evidence of both lean tissue and fat store depletion, giving her a subjective global assessment rating of C. The diet prescribed to her is a low-sodium diet with a 1-liter fluid restriction. However, Mrs. JS is suffering from taste fatigue. She is given a diagnosis of malnutrition with reduced intake and increased losses. As we think about pre-operative considerations prior to undergoing ERAS cardiac surgery, we need to keep in mind that this is a woman who has chronic critical illness with evidence of malnutrition. A nutrition prescription would be to liberalize her diet to include at least 100 millimoles of sodium, potentially improving the palatability. It also makes sense to supplement protein in this woman, particularly given that she's on continuous renal replacement therapy. The use of high-protein oral nutrition supplements might help with this. However, this woman is ill and has persistently poor intake, and if it continues to be poor, we need to be considering the use of non-volitional feeding such as enteral feeding. In this woman, a prehabilitation strategy is not really feasible. She's already in hospital and on pressors and needs urgent cardiac surgery. This obviates the ability to apply a prehabilitation strategy. Carbohydrate loading prior to the VAD insertion is an appropriate consideration in her. In the post-op period, we need to be thinking about early enteral feeding, early mobilization with support, and opioid-sparing strategies, as well as antiemetic agents and pro-motility agents. Let's look at another patient, Mr. LR. This 58-year-old fellow presents with progressive dyspnea and shortness of breath. He has a history of aortic stenosis with a bicuspid aortic valve, and he has an ascending aortic aneurysm. He is slated for aortic valve replacement as well as ascending aortic aneurysm repair. Recently, he's had increasing difficulties undertaking activities of daily living. His past medical history includes obesity, obstructive sleep apnea, and diabetes. On nutrition screening, he screens negative with the Canadian Nutrition Screening Tool. On physical exam, he's 174 centimeters, 112.3 kilos, and has a BMI of 37. On physical examination, he has a reduction in lean tissue stores consistent with sarcopenia, and there's no edema. His hand grip strength is low. His nutrition care in the pre-op period would include education and optimization of protein intake. Adoption of modern fasting guidelines with limitation of pre-op fasting would be appropriate in him. Consideration of pre-op carb loading could be undertaken, however, he is a diabetic, and in this patient population, carbohydrate loading is controversial. In addition, Mr. LR would be an appropriate candidate to consider a prehabilitation program including tailored exercise to improve baseline function and education. In the postoperative period, following aortic valve replacement and aortic repair, early feeding would be the goal. In order to facilitate this, avoidance of tubes and drains would be relevant, as well as using an opioid-sparing strategy with non-opioid analgesia. Nausea vomiting prophylaxis would also be of note and relevant. Mobilizing this patient early with support, building upon capacity created in his prehabilitation period would be relevant. In conclusion, nutrition care in ERAS cardiac surgery is predicated upon nutrition risk screening and nutrition optimization. Standard enhanced recovery approaches to optimize nutrition care would include pre-op carb loading, minimizing fasting time, early resumption of diet following surgery, and the adoption of prehabilitation strategies. I'd like to thank our sponsors for an educational grant that was supplied to Aspen to allow for this program. Thank you very much.